Sjogren's syndrome. Sjogren's syndrome is an autoimmune disease directed against the exocrine glands, the ones producing secretions directed outside of the body, more typically on the skin. The clinical features are due to the loss of these secretions due to gland destruction. Two mechanisms are involved. T lymphocytes are predominantly responsible for gland destruction by invading them and producing pro-inflammatory factors, as well as inducing apoptosis in exocrine cells. The disease seen into these lessons Diseases seen into these lessons are mainly due to the T cells, although there are autoantibodies present and are used for diagnosis but are not pathogenic. So the antibodies are not pathogenic. There is also an intraglandular B-cell activation with the formation of germinal centers within the glands, which can be demonstrated at biopsy. With time, these chronically stimulated B-cell aggregates can degenerate, giving rise to an increased risk of lymphomas in these patients. So here we see that secondary Sjogren's syndrome can happen in rheumatoid arthritis, collagenosis, so SLE, scleroderma, vasculitis, autoimmune thyroiditis, chronic active hepatitis, and primary biliary cirrhosis. Epidemiology. It's a quite common disorder and its prevalence can reach up to 3% of the population. Like rheumatoid arthritis, its age at onset is typically 45-55 years old and predominantly affects females. So a male to female ratio of 1/914. Patients often underestimate this disease because the symptoms are due to the complete destruction of the glands and loss of their secretions. The course of the disease is slow and there is an estimated 6 years between the onset of the disease and the appearance of evident clinical features. We think there could be a possible bimodal distribution of the disorder with a peak during young age. 2030 like in SLE around menarche age, and a second peak of incidence in perimenopausal age. As in SLE, the change in hormonal balance in females is very relevant for the disease. There are two subtypes of the disease: primary Sjogren's syndrome, if it occurs isolated in a patient, and secondary Sjogren's syndrome if instead it's associated with other autoimmune diseases like we saw above. There is an association with lymphoproliferative disorders and non-Hodgkin lymphoma and with certain HLA molecules, DQA10501. Pathogenesis. There are many hypotheses. We think there is an initial exogenous trigger, also predisposed by the peripheral site of the affected glands, like a viral infection that recruits inside the immune system cells, which mediate a cellular-mediated immune response with destruction of the gland cells and secrete pro-inflammatory mediators for an initial regenerative purpose that then perpetuates and amplifies the damage. There is destruction of glands with increased apoptosis that releases autoantigens, and in predisposed individuals, there is the mounting of an unregulated immune response. We do not have a good animal model for Sjogren's syndrome, so there is little knowledge of its pathogenesis. Another characteristic of all these connective tissue disorders is the so-called interferon signature. The major cytokine produced is interferon. For such reason, we always hypothesize that the triggering event is a viral infection, because interferons are typical antiviral molecules, but they are also active against DNA and RNA. Initially, they are secreted to respond against the virus, and then they continue to be stimulated by the presence of nuclear constituents TLRs. If instead you look at the more prominent cytokines in other autoimmune diseases like rheumatoid arthritis, you would find IL-1, IL-6, etc. The intraglandular B-cell activation not only gives rise to monoclonal activation, but also to polyclonal proliferation like the superantigen response. This polyclonal activation can be the origin of the autoantibodies and the generation of cryoglobulins type 2. Cryoglobulins are antibodies which can act at low temperatures, minus 24-25 degrees, which are also triggers for vasculitis and in fact Sjogren's syndrome patients who are cryoglobulin positive also suffer from vasculitis symptoms. Since they don't require 37 degrees to work, they typically deposit at the peripheral and cooler limbs. There are cryoglobulins associated to hematologic disorders, typically type 1, while type 2 and type 3 are associated with certain autoimmune diseases as seen in the classification. So type 1, poor ability to form immunocomplexes, 25% of cases, rarely associated with vasculitis. Type 2, 25% of cases are immunocomplexes containing rheumatoid factor, monoclonal IgM, and polyclonal IgGs. They're involved in chronic infections, especially HCV, but also HBV and HIV, and autoimmune diseases. Type 3 cryoglobulins, instead, in 50% of cases, are immunocomplexes formed by rheumatoid factor and IgR or IgA polyclonals. So here, chronic infections, HCV, HBV and HIV, and autoimmune diseases. The epithelium is the site of the infection, with subsequent interferon production and recruitment of immune cells that amplify the damage. And as a consequence of this, you have increased apoptosis, increased release of autoantigens, and exosomal release of autoantigens. Exosomes are small vesicles constituted of cell membrane and cytoplasm that are released in the circulation by activated cells to mediate crosstalk between each other. Many immune cells, platelets, macrophages, and inflamed epithelia use this system. These small vesicles are a preferred source of autoantigens for dendritic cells. This is especially true for dendritic cells because, differently from macrophages, they are not very efficient at phagocytosis, but their preferred method of antigen acquisition is through micropinocytosis. If the antigen is present within the exosome, it is more easily uptaken and presented by dendritic cells. There is a pre-epithelial infiltrate mainly constituted by T cells, CD4 positive more than CD8 positive, and to a minor extent by B cells. Cytotoxicity is mediated by both kinds of T cells, CD8 positive and CD4 positive, by mediating inflammatory damage but also by fast ligand, perforin and granzymes, which were previously thought to be exclusive of CD8 positive T cells. For diagnosis, you perform a biopsy of the minor salivary gland. You can see atrophy of the gland that is substituted by inflammatory infiltrate. After the initial T cell mediated damage, there is a late arrival of B cells which organize into germinal centers with activation giving rise to autoantibody production, rheumatoid factor and cryoglobulins. Autoantibodies linked to Sjogren's syndrome are anti-ribonucleoprotein, which is anti-Rho SSA and anti-La SSB, that we have seen also in SLE. These are the only autoantibodies we use in the clinic, but they are not the only antibodies produced by these patients. We have then also rheumatoid factor and cryoglobulins, mainly type 3. Plasma protein electrophoresis, you can see another sign of this polyclonal B cell activation, that is hypergammaglobulinemia. If you see a patient with this polyclonal hypergammaglobulinemia and dry eyes and mouth, you can suspect Sjogren's syndrome and perform a diagnostic biopsy. Clinical features are due to loss of secretions with consequent loss of lubrication and antisepsis of dry mouth, eyes, skin, vagina. Inflammation due to friction, increased susceptibility to infections, loss of digestive enzymes of pancreas, loss of gastric acid production in the stomach, all manifestations in internal organs that have some exocrine glands. Symptoms are xerophthalmia, signs are keratoconjunctivitis sicca, so corneal vasodilation and surface irregularities, and can result in corneal abrasion and enlargement of the lacrimal glands. Symptoms are sense of sand in the eye, burning, itching and scraping, and photosensitivity. Xerostomia presents with dry and erythematous oral mucosa and thick saliva. This can cause infections because of the stasis of saliva in the ducts of the glands. Also, a quick test that you can perform in the clinic is to ask the patient to raise his tongue and see after how much time saliva accumulates within the mouth. Angular cheilitis and atrophic lesions of the tongue are also present, inability to swallow dry foods and altered taste, increment of dental caries, swelling of the parotid or other salivary glands, almost like in mumps. The glands become like lymph nodes and are packed with the inflammatory cells. These patients can also have some extraglandular manifestations, such as lymphomas. For such reason, we perform every year an ultrasound of the glands, neck and face, together with gastroscopy because they can also present as maltomas. Diagnosis is done by Schremer's test, which is a measurement of the lacrimal secretion, the degree of imbibition of a strip of paper 30 millimeters wide in 5 minutes. It's positive if it's less than 5 millimeters. Indirect test to check body's ability to produce. It's an indirect test to check body's ability to produce exocrine secretions. We have also staining with rose bangle. So we have marking areas of corneal and conjunctive epithelial damage, punctate and filamentous keratitis, and with slit lamp. Not so frequently performed. It helps to recognize the damage to the corneal epithelium. We have breakup time, so application of a fluorescein drop and measurement of the extent of the marked tear film breakup time. If lacrimal secretion is normal, the film produced by the fluorescein drop will remain intact for a couple of seconds. If instead your lacrimal secretion is of bad quality, then the film will break up much more quickly. With biopsy of a minor salivary gland, you never perform a biopsy of the parotid gland. We have imaging, so echography, MRI, salivary glands again also for monitoring. We have shylography or scintigraphy to have another indirect measurement of the gland secretion ability. Differential diagnosis with Zika syndrome, especially at the beginning, can be very difficult because there are also other diseases which can give rise to this symptomatic dryness, such as sarcoidosis, amyloidosis. In this case, biopsy will be diagnostic, hemochromatosis, deficiency of vitamin A or C, which is rare in our countries, more rarely squamous cell carcinoma, and more rarely scleroderma, systemic sclerosis, and other connective tissue disorders, lipoproteinemia type 4 and 5. Other manifestations are linked to other sites of exocrine glands. We have in the upper respiratory tract, hoarseness and chronic bronchitis and increased pneumonia rate due to impaired tracheal circulation and dryness. Exocrine pancreatic insufficiency, hypochlorhydria, dry skin, reduction in vaginal secretions. Extraglandular manifestations can be divided in those that always involve epithelium and those that are due to extraepithelial inflammation. In the extraglandular epithelia, we have at early onset T-mediated good prognosis. The clinical pictures are interstitial nephritis, so kidney involvement, liver disease and gastropathy, and obstructive bronchiolitis. In the extraepithelial inflammation, it is inflammation with completely different targets. It's a late onset, antibodies and immunocomplexes mediated bad prognosis. The clinical pictures are vasculitis with palpable purpura, glomerulonephritis, peripheral neuropathy, more rare but present, due to terminal nerve inflammation. We have non-specific symptoms common to connective tissue disorders, so fatigue, which is significant, arthromyalgia, pain in joints and muscles, low-grade fever, arthritis in 50% of cases, which can be polyarticular, non-erosive, with respect to lupus, and Raynaud's phenomenon due to some extent, 35% of cases. Gastrointestinal manifestations are in part due to the defective secretions and in part due to the extraglandular and extraepithelial manifestations. Dysphagia, nausea, epigastric pain. You can also have anatrophic gastritis. You have hypopharyngeal or esophageal, or can be esophageal motility disorders, like in systemic sclerosis. We have pancreatic damage, so with a persistent hyperamylasemia, which is the most frequent abnormality detected, and acute or chronic pancreatitis, which is less frequent. We have chronic hepatitis, so with hepatomegaly, 25% of cases, laboratory test abnormalities, increase in ALP, AST, ALT, GGT, MAA+, and inflammation of the bile duct like primary biliary cirrhosis. Vasculitis, together with achloride and pancreatic involvement, are pretty frequent, with palpable purpura typically at lower limbs. The lesions can be easily seen and also felt under the skin, thus the name palpable. It is present in 5% of Sjogren's forms, Sjogren's syndrome forms. The clinical manifestations are palpable purpura, urticaria, or recurrent skin ulcerations, mononeuritis multiplex, kidney, lung, GI, spleen, breast, rare damage. At the histology, we see neutrophilic, cryoglobulinemic vasculitis, and monocytic. So, primary biliary cirrhosis is a chronic granulomatous intrahepatic cholangitis of unknown etiology. It has a late onset of symptoms, and 70% of cases are associated with Sjogren's syndrome. We have typically positive mitochondrial antibodies, antimitochondrial antibodies, and the therapy is liver transplant. We can have also kidney involvement with interstitial nephritis and glomerulonephritis, which is more uncommon. Less common. We have lung involvement, so cough from xeratotrachea, dyspnea, recurrent bronchitis and pneumonia, localization of lymphoma, and other manifestations are autoimmune thyroiditis in 50%, 15-30% of cases, CNS involvement, so peripheral neuropathy, vasculitis, and damage to the CNS, which is controversial, and lymphoproliferative disorders. Um, European criteria needed for the diagnosis are eye symptoms, oral symptoms, sinus eye, Schremer test, Ross-Bengal test, involvement of the salivary glands, scintigraphy, shallography, decreased salivary flow, biopsy, minor salivary glands documenting lymphocytic infiltrate, with a focus score more than 1. For diagnosis, it's necessary to have more than 4 out of 6 criteria. Exclusion criteria are sarcoidosis or existing lymphoma, AIDS, other causes of keratitis sicera or adenomegaly of the salivary glands, previous radiotherapy, or graft versus host disease. The autoantibodies are SSA positive, SSB positive, and antinuclear antibodies, rheumatoid factor, and antigastric parietal cells.